Hello, and welcome to the Decolonizing Madness short interview series, where we introduce and speak with various scholars, practitioners about their research, collaborations, and projects as they relate to debates around illness, psychiatry, and culture. For our first short interview, we are very happy to welcome Margret Jaeger and Mustafa Abdalla, who will speak to us about their collaborative project of training health practitioners in Egypt in medical anthropology, with a small section on maybe mental health and illness and culture. Margret Jaeger is a medical anthropologist and head of research unit at Fonds Soziales Wien, Social Funds Vienna. And Mustafa Abdallah is a medical anthropologist and an associate researcher at the Institute for Social and Cultural Anthropology at the Free University of Berlin and co-director of the Institute for Advanced Studies in Nantes. So welcome to you both. Very happy to do this interview with you. Maybe we first start by talking more about your research and your work and introducing yourself to the audience or the viewers. So Margret, maybe we start with you.
Thank you, Lamia. Thank you for the invitation. Yeah, I'm a medical anthropologist from Austria, and I'll educate health professionals around the globe, medicine, nursing, occupational therapy in different countries and different languages. And since a month, I'm the head of the research unit that is recently founded. And our main tasks is to organize research about care and nursing staff in the city of Vienna to improve, because you know that nursing staff is lacking in whole Europe, and research is needed, and we also will take care of the diversity management, because we are an educational institution as well. We educate non-academic nurses, and therefore diversity is an important issue for teachers and students there. And one of the new researches I'm going to do is hospital ethnography, but in the design of rapid assessments, because in applied work, you don't have time for ethnographies of taking like 1 year or two. It needs to be faster. And looking forward to do research in mobile care teams, in classical hospital wards, and also in long-term nursing homes, mainly elderly care.
Thank you, Margret. Mustafa?
I do research with patients in Egypt, and this is a group of patients that I call professional patients. This is actually my current research. And these are a group of patients who find value in their diseases and try to commodify their diseases in order to produce or generate income, to take up social responsibilities and for their families, which means that they generate income by participating in medical school scenarios like bedside teaching, or during the examination period, they take money from the students and the assistants, and with this money, they try to provide for their families, to support them, to help them. So basically, it's about the diseased body that supports the healthy body, the diseased body that generates income, that supports the unemployed healthy body that's unable to produce or generate income to support themselves.
Thank you, Mustafa. I'm very happy to introduce your collaborative project on training health practitioners in Egypt. And I took a very small part in this project, perhaps at the beginning of it. But unfortunately, I couldn't stay for longer than that. But I'm curious to know more from you on why training? Why do you think medical anthropology should become a tool for training for health professionals? And how did this project started? What were the kinds of debates or the kinds of gaps or tensions that provoked you to suggest this kind of project, especially in Egypt? So we start maybe with Mustafa, perhaps.
Actually, I did my research for my doctoral degree in a medical school, and I worked with the students. I interviewed them about their experiences in learning medicine and so on and so forth. And through this research, I came across lots of aspects about tensions and conflicts between them and the patients, the medical staff, and so on and so forth. And later on, I provided some talks, kind of informal talks, but also formal talks, to where lots of students, medical students, came and attended, and they were very interested in the idea of medical anthropology and the kind of visions that it provides, the kind of solutions it provides, and the kind of explanations that it provides them to understand these tensions and these problems. Then when I started to work with the professional patients, also in medical schools around Egypt, they were very interested in the kind of work I do, and then more and more students and medical people were interested in the kind of work I do, but also the idea and the concepts of medical anthropology. And that's why I decided with colleagues, one of them is Margret, to organize a medical anthropology workshop in Cairo to medical professionals, but also to medical students. And this is where we felt like there is a need to provide or to cater for this need that's really growing. We started to think about doing something for these students, but also not only something, that one time and it's over. No, we were thinking about something that's sustainable. And this is when we started to think about starting a training of trainers that would cater to this growing need in medical schools among the medical students. And we provided several workshops to medical people and to medical students. And we could also feel how important it is to start this project. So we started to think about, we launched the call for applications, and then we received applications. We selected a number of students where we started also the training, where you also part of it. And we finished it last November 2021.
Thank you, Mustafa. Margret, I'm interested in also if you can tell us more about what kind of tensions specifically, or what are the needs specifically that you've seen within the medical school and the health professionals, and what kind of medical anthropology tools was Mustafa talking about?
So if you look at medical education, there is the World Federation of Medical Education, that has a recommendation published in 2020. And in this recommendation is clearly written, medical schools have to offer teaching in social sciences, especially in medical anthropology, so that medical professionals later are trained well to work with people. Every university that offers medicine and wants an accreditation from this WFME organization needs to put in place that. So there is the other side of the coin that Mustafa is saying, that he saw the need and people were relating. The organizations, the universities have this pressure from this side. And on the other side, you have many graduates from anthropology leaving academia after graduation, and there are no academic jobs out there for them. But there are jobs in health education, not only in medicine, but as well in nursing and other professions. And what I saw from my experience what is the double thing in this team, like you need somebody regionally located with the regional knowledge, and you need somebody with a lot of teaching experience. And this teaching experience, which was my own like learning by doing years ago, showed me, okay, but you need to train young people in that, because there is a job market, it's much needed. It really gives you the chance to work for society as anthropologist, but you need training. And so far, we both have not met any faculty around the globe that offers these type of trainings in a very structured way, and regionally rooted. Because of course, what you have is in medical education in the US, they have to be certified as medical teachers, and that's totally different. But in other parts of the world, you sometimes just get into medical school accidentally, or there is this one single space for you and you open a door, and but there is this international recommendation, and that's very powerful.
I'm interested in, oh, go ahead, Mustafa.
No, I just wanted to say that that was actually the approach where when I started talking to medical schools, I talked to some of the deans and I explained to them the importance and the need. And when they saw this statement, they were very interested. But also working with the students directly or talking to them or starting this dialogue with them was also a motivation, for the medical school leadership to accept and understand the need for medical anthropology, because some of the students themselves went to their deans and their professors and talked to them about the importance and about what they learned about medical anthropology. And through the students and through the introduction that was made by the students, some faculties of medicine, they started to invite us and asked us to come and provide workshops and talks there. And I remember in one medical school where we went to provide 2 workshops, they insisted on having not only 2, they wanted to have 4 workshops, right, Margaret? As far as I remember. So we went to provide 2 workshops, and we ended up providing 4, because the need was, there was a high need, and they insisted on that. So it showed that there is a strong need among the students, but also there is an acceptance from the leadership to this idea or new ideas to come into medical school. Yeah.
Thank you, Mustafa and Margaret. I'm interested to talk specifically about the nature of these workshops or the nature of this training. So what is it that, how do you turn medical anthropology into tools, into training and teaching tools? What kind of concepts you thought were relevant to health professionals in Egypt, or to train them in certain ways? Basically, what did and how would anthropology or medical anthropology help with making the medical practice in Egypt a different practice? So I'm interested in you talking more about the nature of these workshops. So what kinds of tools did you use? How did you develop your curriculum? What are the concepts that you relied on? Maybe we start with Margaret.
Okay, yeah, great. So the curriculum development was based on 3 pillars. One is an extensive desktop research going on for years, information from a group I founded in 2015 within the Medical Anthropology Europe network of the European Association of Social Anthropologists. We founded a special interest group called Teaching Anthropology to Health Professionals. And there we collected a lot of experience from colleagues, mainly from Europe, but not all. So this informed our content. My own experience of trainer and my exchange, my really extensive exchange, but also research experience and the experience of being a patient and having bad experiences, what's going on in healthcare. And the same discussion from Mustafa coming in, of course, what's going on in Egypt for patients, for doctors, etc. Mustafa's experience from Egypt was fundamental in this, of course, because you need to root such training if you train local trainers in local experience and local reality, in local context. So this is very fundamental. And there is another point that it's important, and it's really a message for me, because health professionals tend to criticize people who work in health education without being a health professional. So they question you as anthropologist or as social scientist a lot. And I found out there are basically 2 ways to get rid of these critiques. One is doing internships in healthcare settings. And the other one is gaining a deep knowledge on how healthcare is organized in a specific country. Finances, professional education, NGOs, politics. Why? Because health professionals are experts in a very narrow field, but they don't get these context things. But it's important. So one thing that you teach is trying that medical students get a broader view and see context. context in a very broad sense, but it's eye-opening for them. And you need to be prepared because people have cultural shocks by understanding more and more of the system, and they also will say, okay, some things I will never have the power to change, but I will have to deal with that in practice later. So your position as teacher is not only one of, it's not only transmitting knowledge to them, it's giving them tools, as you said, from anthropology, and developing their reflection competence. It's, I think, kind of politicizing them as well sometimes, and showing their relevance as advocate for the patients sometimes, which is new for students sometimes and sometimes not, depends a lot. Yeah, so these are the three pillars where this was constructed based on a blended learning experience, having an online training originally going on for 5 months. Then there came this little virus and messed up our plans. So it turned into a 15-month online training and 1 week on-site training in Cairo, which was always planned like that, and which happened finally in November 21.
Okay. So we can say that maybe medical anthropology, different concepts, I'm still would like to know what concepts you use, but they helped you or help these health professionals get a deeper sense, a deeper knowledge of the system that they are in, and maybe expand their practice to include more of critique or more of new ways of understanding maybe patients or diseases. Mustafa, can you tell us more about that?
Yeah, we actually provided, for instance, workshops about social economic determinants of health. We did also workshops on health literacy, and we did not lecture. We did not provide, the kind of lecturing sitting. It was more of a debate, a dialogue to understand, and also to put them in the place of the patient, and to put them in the to think about what exactly happens for the patient. Why don't they abide by the medical rules, for instance, for sometimes? Why are they suffering from certain diseases? Why don't they buy the medications when they ask them to buy the medications? Why do they eat the kind of food they eat? Sometimes while they are not supposed to eat it, or or it's harmful for their health. And we started to think with them about the environment around them, and its impact on health, the kind of food that's being sold even in the medical school itself, and how it affects their health. And they started to think themselves about these concepts, about these issues and problems that are facing them on a daily basis, thinking about the medical school and the environment where they go and study or learn, the environment of learning, which is the medical school, the environment of where they live, and the kind of food that's being offered for them in the medical school, and the garbage around them. Yeah, we didn't even tell them about the garbage. They started to think about it, and it was very interesting when they formed a kind of a group, a discussion group, and I had a meeting with them one day around midday in the next day, and they were up until 3 in the morning discussing and thinking about what exactly happens around us that causes harm to our health. And then they came in the next day with a list of things to discuss with me, and how to do and what to do exactly in order to improve, the health situation. And these were medical students and faculty members, which was also interesting to see how they are engaging, young faculty, how they were engaging together and entering into a dialogue, which they don't experience often. And then they came up with this list to discuss with me, and they were asking what to do. How can we improve these things? And I asked them about it. I said, okay, well, let's go and talk to the vice dean And then we went together and talked to the vice dean. But interestingly, one of them, and this is a faculty member, she says, I discovered that the kind of food, even the kind of food being offered in the medical school, you know, for us as medical people is not healthy. And we are doing this every day. And she discovered that the kind of food or the kind of the healthy food that she could eat would be even much cheaper than the kind of food that is being offered in the medical school. And she said every time now, until this moment, every time she goes or she sees the kind of food that's being offered, the kind of fatty food being offered in the medical school or wherever else, and she thinks about buying it, she remembers this workshop and she stops. She doesn't buy it anymore. So it was really interesting to see this kind of development, you know, and the process they went through, and the kind of dialogue they entered, and how they started to see things differently inside of the medical school, how they started to see the patients differently, and how they started also to engage with the faculty members in different terms. And that was, I found this really rewarding and very interesting. Yeah.
Perhaps what you're saying, Mustafa, resonates with Margaret's comment about them having a culture shock. But I would think less in terms of culture shock, or and more in terms of disciplinary maybe shock, or this kind of realization that the way they've been internalized their own practice is very specific, and then maybe anthropology can bring in this other ways of seeing illness and seeing the world, and becoming a doctor that and can give you all these kinds of rich tools to see these kind of things.
Exactly. It started to make things visible for them. Even though, as I said, we did not do a kind of lecture and tell them, listen, the kind of food you are eating out there is not good for your health. No, we started to ask them questions, provide them with certain activities they do, discussions, you know. We put them in groups to think together about these aspects, and they came up with fantastic ideas. I mean, it's the outcome was developed by them and not by us. We didn't provide anything. And I think personally, if we would have come to teach them, you know, the way of classical teaching about the determinants of health, whatever they are, or about health literacy and how people deal with the environment around them, and do they know about health or disease, or do they know about their bodies or anything. I think if we would have done this, we would not have reached the kind of outcome that they reach themselves through discussion, debate, dialogue amongst each other.
Margret, do you have anything to add?
Yeah, so what Mustafa was talking about was the experience in 2019, which informed a lot the training then, yeah, which showed, okay, where trainers need to go, where is the status of the students, what's going on. We were in a medical faculty in Cairo, yeah, so you could see, as he said, the learning environment there, yeah. And how should you learn medicine, which is a very stressful study, when you're not provided with healthy food, and when it's loud and dirty and whatever around, you know? So this informed a lot. What we thought, I have decided that it's important is, for me, for example, explanatory models from Arthur Kleinman. Why? Because we all have our own explanatory models about everything. And they depend on so many factors, and they depend actually on the social determinants of health, because this is a very broad concept, and this changes as well, but it does not mean that medical students or even physicians don't have weird explanatory models, you know? And therefore, I still think some people think it's outdated, but we use it a lot here in Austria, and our experience showed that it's really helpful, and it's easy to teach, it's easy to explain. You can collect cases based on this. And you might know, when you look at the cultural information interview, which is a tool from psychiatry, and this, for example, is an important tool that shows how medical anthropology knowledge is applied in practice, and how important in this tool you ask in there for explanatory models, and you ask in there for the suffering experience. Mm-hmm. So it's important as well, if you think back, and it's quite old, but it's really helpful, the distinction between disease and illness. Because in that moment where a person gets sick and feels ill, you decide what to do. And at some point you decide to see a medical doctor trained in a biomedicine Western style. And then you expect a diagnosis on a specific thing and a suggestion for a therapy that works. But that's not like medicine works. It's not always possible to make a diagnosis. And this is not only frustrating for the patients, it's also frustrating for the doctors. Mm-hmm. If I think about 8,000 rare diseases currently on the list, there is many cases where a physician cannot offer a quick diagnosis and suffering increases. And having this, talking about suffering experience, like creates more empathy in medical students, yeah? Showing them the other side of where they use so much that the ICD, since this year it's the ICD-11, but it's sold as a gold standard, but for some people it's not a gold standard because, or even there's no treatment in your country. Like in the case when you have low resource countries, yeah, you might get a diagnosis, but then we can't offer you locally good care, for example. Mobility was one aspect we taught, because the concept of mobility is much bigger than migration. And in the case, I think not only for Egypt, but probably for other Arab countries and for many countries on this planet, is the high mobility of health professionals. I personally was shocked when I first went to Egypt in 2019, and I met so many medical students speaking well German because they wanted to go to Germany after medical school, speaking very well English, telling about their plans to leave Egypt to UK. So it's not only the incoming migrants for many different reasons and refugees, but it's themselves getting migrants at some point. And then you have a huge cultural shock because a health professional, medicine is culture. We taught this as well, yeah, that they don't think that medicine is this neutral thing. Yeah, let's say anatomic parts. We all have 200 bones normally, and certain organs normally are placed in certain places inside our body. But medical knowledge is rooted culturally. And when they migrate, they face very, very strong differences. And a health system may ask them for many different things they have never heard about or they were encouraged not to do in their home countries. Mm-hmm. And in countries, I think, where high mobility of health staff, of outgoing and also incoming, because incoming means you need diversity competence to deal with your colleagues, to work well together. So we had aspects about diversity and diversity management as well.
Thank you. Decolonizing Madness project is mostly interested in the relationship between illness and psychiatry and power and culture, and the different ways in which psychiatry has been reconfigured historically, but also in different geographical sites. Did you focus in your medical anthropology training on mental health and mental illness, or on conceptualization of illness and its relationship to culture? Did you think that this is useful for doctors and health professionals in Egypt?
I definitely think it's important. By getting your question before I started reflecting on it, and I saw, yeah, we did not have one special section on mental health, but it came up all the time in the training and from very different sides. For example, we started discussing how to become a physician, how to become a health professional, and how stressful is the way to go there, and how much is this demanding from the students themselves, from their mental health perspective. And they feel destroyed when they leave medical faculty. Yeah? How should you offer good care to people when the whole education is so stressful? Then it came up, for example, as well, we talked about stigmatization and following then discrimination of people in healthcare. And the students themselves mentioned how strong as well health professionals, and they talked about physicians, discriminate people with mental illnesses, and how difficult it is to get good care, and how society sees mental health. And actually, we are talking much more about mental sickness and mental illness, because the focus is not on mental health in many countries to prevent mental illnesses, but on treating already sick people. And many countries have undergone psychiatry reform as well, and many things have changed there. Once they're out in practice, of course, and we address that as well, there is this understaffed teamwork in the Egyptian case with low resources, aggression against them from patients and family members, and how to address that. And there is a brand new concept which we could not address as much as I wanted, but we gave out information, and we talked about them to work about this further, is structural competency. A concept developed from 2010 on in the US from a group started in Berkeley. First texts are from 2014. And today there is out in MedEd portal a whole training. It's only 3 hours training that you can take all the information, train trainers quickly, and train students about structural competency. And I think this would be crucial, actually, for medical anthropologists to be experts in structural competency, and give this further to future health professionals, because it helps you to understand inequities in healthcare. And I personally think it helps them to find their role as health advocate for their patients, because sometimes they are the first and only who will be able to do something for people who suffer inequalities and inequity in healthcare. And we know all this is power relations. So I think it's a very important competency that we could not focus as much on as we wanted to, because it was a basic training, and you always have to take decisions.
Mustafa, do you have anything?
I just want to add something very small, which is actually we did not touch upon the issue of mental health per se, but actually I found it really interesting to see the trainees and their need to talk about distressful encounters they had once they started practicing medicine. Yes, I mean, learning medicine is stressful, and it was extremely stressful for them, given the fact that there is lack of contact with patients. They feel like they are lacking the experience, and so on and so forth. They just wanted to pass exams and go on with the practice, thinking that once we start practicing, we are going to learn. But then they were thrown in places, to start practicing medicine. They were employed in these clinics or hospitals, remote places, and all of a sudden they started to face the medical realities. Medicine is not easy, and it's not easy when you are alone. You don't have somebody to consult with or to talk to exchange with, and so on and so forth. And I found it fascinating when they came and they started to talk about encounters they had once they started practicing, problems that they started to to discover and realize how difficult it is. Issues and problems that they had to deal with, with the patients, working with the patients and their families, and so on and so forth. Sometimes they were like easy issues, that could be solved, but they were surprised that people don't pay attention to that. But then here came the idea about health literacy and what kind of knowledge people have about their body, about disease, and about health. Also, the idea of the social or economic determinants of health came in, but I felt like there was a need for a space, to talk and express all of these tensions and problems that they have been going through. And I remember, I don't remember like a definite example, but I remember, I mean, sometimes it took them really a long time to talk about these experiences and to express how they felt about, certain tensions, certain problems that they are facing when they started to practice medicine. And I found it very interesting, but also I could see that they are missing the space, or maybe a safe place for them to be able to share these tensions, to share these problems and talk about them. And I think they found it also in this context, in the context where there are other medical people, because many of the trainees were with a medical background. And once one of them started to talk about her problems, the others followed to talk about the issues that they were facing and so on. So I think there is a need for that, and there is a need for a safe space to express themselves.
One final question I have is, what do you see the future of this collaboration, the future of this project, or what kind of outputs would you want to see now in the people you train? But I would add also to what you said about the mental health and mental illness, that I would love to, if this collaboration continues, to see something beyond the practitioners themselves, their own mental health. There's so many things to do about the illness of the patient, and sort of the dichotomy between mind and body, and to think with health practitioners about the sort of the life world of illness and how illness can be expressed in so many different ways. And then perhaps this is also a useful tool to train in your future sort of projects.
You're bringing up, Lamia, that we have talked about body, of course, and there the mind-body dichotomy was brought in, and especially for very severe sick persons or chronic patients, patients with chronic diseases, those things, and mental health gets more and more difficulty for them. And we also had the aspects of faith. And faith, can do very good to people when they are sick, but it can also harm people a lot. And faith of physicians can harm people and can do very good. So we have addressed those topics, I think, just not under the label of mental health, but yes, there is definitely should be more space for that. It's kind of, I see it as like this was a pilot, and you have to find out what is needed. And in this case, the reflection is, you were asking about the outcome. The outcome is a syllabus to teach a certain group of medical students a voluntary course. They have decided on the topics. They have developed the training materials. I have assisted in constructing the syllabus with the knowledge I have. And it exists now in Egypt, and they can take it and go to medical faculties. And I've just had a talk with them this week, an informal gathering, and one of them had told me how she's now the social one in a new training she's doing, and they started asking her, and she's giving them input, and she was asked to give more input on medical anthropology. So slowly, but step by step, I'm sure these seeds that had been planted with this pilot training will grow to plants, and we will see fruits growing. By the end, it's a question of money. You need money, you need investment, you need time, you need teams, you need resources for offering this, and hopefully medical schools also see the need. It was lovely to see how empowering it was for the female-only participant group. It's really, by the end, when we met them on site in Cairo, and they started trying out what they had developed in the syllabus. It was amazing to see. As a trainer, it's the biggest pleasure you can see when you see people growing and gaining confidence and speaking up at the end. We also had an important outcome, which is a case collection for teaching that can be used, because case teaching is the standard in medicine, and anthropologists are not trained in this, and it's very important to train people on this and have a certain method how to report cases, which we used as well. And to talk about the future, I personally would like to see a global network for medical anthropologists in health education. I think this would be very useful for many people, but it needs resources, of course. It may need an institution or organization that hosts that as well. And then you could start a real support each other and exchange and develop further materials, because without local grounding of teaching material, you will always miss something. And you see this in the structural competencies. It was developed in the US, and now people from all over the world are going to adapt the teaching material for their local realities, languages, and cultures involved. And you need teaching material being developed on this level to be able to have an impact later, because the impact can only be seen in practice when physicians and health professionals feel, okay, this knowledge times ago is helpful now to not have a conflict, to solve a problem, or to intervene in a conflict, because I can apply what I have learned days before.
Thank you, Margaret. Mustafa, any final thoughts about this subject?
No, Margaret provided the most important aspects. So thank you so much.
Thank you so much for both of you for participating.
Thank you. Thank you for giving us this opportunity to talk about this training and this initiative, Lamia. Thank you so much.
Thank you, Lamia, for the invitation.
Absolutely.